legally need to tell people that. So I've turned that recording on. So if you'd like to watch this again or share it with any family members, friends, or even your doctors, it will be housed on our website, and we'll send you the link in the next couple of days. So welcome to our webinar. This series is called Prepare for Victory, our virtual medical symposium series. We created this program because we want to give you, no matter where you are in the world, the opportunity to hear the best information on Marfan and related conditions from our professional advisory board and other leading medical professionals on these conditions. I'm gonna get my slides going here. Today, we are starting appropriately with Marfan 101, a basic overview of Marfan syndrome. Our speaker tonight is Dr. Luciana Young, a pediatric cardiologist at Seattle Children's Hospital. Dr. Young, who was previously at Lurie Children's Hospital in Chicago, has been in Seattle for the past couple of years and was recently named to our professional advisory board, and we are so thrilled to have her. If you have questions during the presentation, please type them in the Q&A box, which you can see on your screen. We will leave time at the end to answer questions. Please remember, and this is really important, that this presentation is an overview. We're not gonna, Dr. Young is not gonna go in depth in every body system. That would be way more than an hour, for sure. During the Q&A, she'll answer general questions and questions related to heart issues. If your questions are too in-depth or if they're very detailed about body systems, I will take them afterwards and I will forward them to Jan Lynch, the nurse who heads our Help and Resource Center. And then she can work with our other specialists so we can make sure we get you the answers that you need. So, we'll go through the questions that we get and be able to, and try to answer as many of them as we can that are appropriate for this venue. So I am now going to keep my fingers crossed, hope this works, and give Dr. Young the mouse so that she can take you through her presentation.
And yes, it worked.
Oh
you
my
see
God.
it?
I do see it. Wow.
Great.
We're good.
Right. Good start. So thank you so much, Eileen. Thank you for inviting me to give this presentation. And thank you, everybody from all over for coming and joining us today. I know that it's quite late at night or early in the morning for some of you, and we appreciate you being here with us. And I'm sorry that my emails are popping up on there, so I'm going to try and get them off. So today, as Eileen had mentioned, it's basically an overview of Marfan syndrome, understanding the basics. I am a pediatric cardiologist, and I will admit that it was a little bit tough for me to not focus too much on the heart on this presentation and keep it more general. But I've done my best, and hopefully you'll get much of the information that you need, at least starting out with Marfan's from this talk. So the objectives today will be to learn about Marfan syndrome, including what causes this condition, who is affected, and what are common signs. We will consider some of the related disorders with findings that may overlap with Marfan syndrome. We'll discuss how Marfan syndrome is diagnosed and some common tests you might expect when undergoing evaluation. And briefly review some of the recommended management. Again, not going into too much detail because that will be coming up in further series down the line. So to start out, Marfan syndrome is a genetic disorder that affects the body's connective tissue. The connective tissue is a substance that's made up of lots of different proteins that's found throughout our bodies and holds our cells, our organs, and our tissues together. One of the important proteins that makes up the connective tissue is fibrillin 1, and this is the particular protein that is affected in Marfan syndrome. Defects in the gene which makes fibrillin 1 cause an increase in another substance called transforming growth factor beta, or TGF-beta, which causes problems with connective tissue throughout the body. Marfan syndrome occurs in approximately 1 per 5,000 individuals. Males are affected just as equally as or frequently as females. All races and ethnic groups are equally affected. It's an inherited condition, meaning that it can be passed on from parents to children, and it has an autosomal dominant transmission. This means that there's a 50% chance that a person who has Marfan syndrome will pass along the specific mutation each time they have a child. So for example, if a person has a child, that child will have 50% chance of having Marfan syndrome. If they have a second child, that second child also has 50%. It doesn't change the frequency of the transmission with the number of pregnancies you have. Each time it's a 50% chance. 25% of mutations occur spontaneously, meaning that they occur in the first time in a family. So what are some of the signs of Marfan syndrome? Well, the features can be present at birth. Typically, when they're present at birth, they're much more severe than individuals who present later in life. The findings can develop with time as someone ages, and they can become worse with increasing age. The signs are variable in expression, meaning that every individual is affected differently. So for example, even in one family, if there are several family members affected, each one may have different findings. One person may have more eye problems, another may have more skeletal issues, and yet another may have more cardiac issues. So again, variable expression. The affected systems in Marfan syndrome are the heart and blood vessels. These are probably one of the most important because they can lead to the highest complications, morbidity, and mortality related to Marfan. Bones and joints, eyes, lungs, skin, and spinal cord, and we'll take a little time to go over each of these systems a little bit later in this discussion. There are several disorders that can be related to Marfan syndrome, which also include the connective tissue and therefore can have overlapping findings. One of the findings can also be progressive enlargement of the aorta, and complications related to the heart may be similar and sometimes either less so or more so in these related disorders. A few of these related conditions include Loeys-Dietz syndrome, Ehlers-Danlos syndrome, or familial thoracic aortic aneurysm and dissection syndrome. Now, the heart and blood vessels, typically what we see with Marfan syndrome is progressive aortic enlargement. This is a diagram of the heart. Here we see the aorta, which is the great artery which leaves the left side of the blood and carries oxygenated blood out to all the different organs of the body. From here, the coronary arteries arise that give blood to the heart muscle. It is this early portion of the aorta, or the closest portion of the heart, that typically enlarges, and over time, this progressive enlargement can lead to aneurysm formation. An aneurysm means an increase in size of the blood vessel greater than 50% of what is expected to be normal. This aneurysm can develop or can lead to progressive aortic valve leakiness or insufficiency because the ring that holds this aortic valve in place, allowing blood to not back up into the left side of the heart, is held in place in part by the aorta. And as this blood vessel enlarges, the leaflets of this valve cannot close properly, and therefore leakiness can develop and increase over time. Because these walls are very thin, almost like a water balloon in some cases, there can be occurrence of tears or even rupture of this blood vessel, which can be an extreme emergency and possibly even fatal if not treated promptly. We'll talk a little bit about that and what signs or symptoms to expect with that in our next slide. Other findings that we can see in the heart are floppiness of the valves, in particular the mitral valve, which is also on the left side of the heart and connects the left atrium or the upper collecting chamber to the lower chamber called the left ventricle or the pumping chamber. These valves are also made of connective tissue, as are the muscles or the tendons that keep them in place and allow them to open and close. The valves become floppy and over time can also develop progressive leakiness or insufficiency. Because of this floppiness and sometimes because of the leakiness or dysfunction of this valve, it can affect the left side of the heart with left heart enlargement, left heart dysfunction, and also at times abnormal heart rhythms can develop. Other valves that can be affected that are not listed here are the tricuspid valve, which also can become floppy here on the right side of the heart. There can also be enlargement of the pulmonary artery, which is the artery that goes out to the lungs. Aortic dissection is, again, an emergency. What happens with an aortic dissection is that there is a separation of the inside of the wall of the aorta that over time can progressively enlarge and extend further distally or further out into the aorta as blood continues to pump and push and separate this wall further. The typical signs of an aortic dissection are severe pain of sudden onset in the anterior chest, back, and or neck. And again, because this can progress and because these tears can sometimes lead to dissection or rupture, or excuse me, not dissection, but rupture, they are considered a medical emergency and should prompt medical evaluation as soon as possible. Other systems that can be involved are the bones and joints. Individuals with Marfan syndrome are typically very tall in stature. This is secondary to bony overgrowth of the skeleton. Other findings that we may see are flattening of the feet or absence of the arches of the feet. This can often lead to foot pain and need for orthotics to be placed in the shoes to help with walking. There can be inrolling of the ankles here that can also lead to ankle pain, hammer toes. Oftentimes the joints are hypermobile, meaning that they're very flexible and very extendable. There are certain signs that are frequently associated with Marfan syndrome and hypermobile joints. One of these is the ability to extend the thumb, or this is called the positive thumb sign, all the way over and pretty much bend it over so that you can see it extending over to the other side. Also, there's another sign called the thumb to fifth digit sign, which allows overlap of the digits around the wrist. The fingers are typically very long. Another word that you might hear for this is arachnodactyly. Other skeletal findings include chest wall abnormalities. Pectus excavatum is a caving or a caving in of the chest that typically seems to be more of a cosmetic feature and not so much related to any physical findings or symptoms. Sometimes, however, it can become severe and can cause problems in terms of exercise tolerance and lung expansion. Another form of this pectus abnormality is pectus carinatum. In this particular case, the chest wall protrudes out almost like a pigeon chest, and this is what carinatum means in the Latin term. Other findings include curvature of the spine, which can be progressive. Another word for this is scoliosis, and can sometimes require either brace, wearing of a brace to help correct this finding, and sometimes surgery to realign the spinal column may be necessary in some severe cases. High arched palates are common, as well as crowding of the teeth. Oftentimes, individuals will need placement of a palatal expander to open up the palate, and some type of orthodontia or braces to be placed to realign the teeth. Another system that is frequently affected in Marfan syndrome is the ocular or the eyes. Myopia or nearsightedness is a common feature. I like this particular slide because most people have trouble seeing the forest through the trees, but in myopia, it's trouble seeing the trees through the forest. So I kind of really like this image. Ectopia lentis is another distinct feature of Marfan syndrome, and you can see here that this opaque area right here is the lens of the eye. Typically, this would be right in this area here, but this has slipped off and dislocated out into this sort of superior aspect of the eye. And this dislocation of the lens can lead to eye problems and visual problems. It is actually the ligaments that hold this particular lens in place that are also hyperextendable and also loose, just like other ligaments elsewhere in the body, but they're also present in the eye and help keep the lens in place, and in affected individuals, therefore can lead to displacement or dislocation of the lens. Another finding that can occur are cataracts or clouding of the lens, which can also lead to problems with vision. Glaucoma, increased pressure within the eyeball. And retinal detachments or tears within the back side of the wall and separation. These are all pretty significant eye or findings that can lead to visual disturbances and sometimes loss of vision. Pulmonary findings are also frequent. One of the most frequently discussed findings is a pneumothorax. This is a sudden lung collapse. If you have one, you'll know because it's pretty sudden in onset, very severe chest pain and difficulty in breathing. This occurs, again, suddenly and without necessarily any type of impact or any type of injury. It just occurs spontaneously. Other findings in the lungs, because the lungs are also made up of connective tissue, which is weak and doesn't hold the cells and tissues well together, are that the lung buds, which allow us to ventilate and oxygenate our blood and allow for air exchange when we breathe in and out, can, rather than look like bunches of grapes, they become kind of cystic and start to lose the walls in between them. This leads to hyperexpansion of the lungs and can also lead to breathing difficulties. And finally, because of abnormalities not only in the connective tissue, but also other abnormalities such as the high palate, dental crowding, chest wall abnormalities, individuals can have problems with sleeping. Snoring is one example in which when the head is laid flat, the airway falls back and actually causes obstruction during the breathing cycle and closes the upper airway because of collapse of the tissues to the back side of the airway. This can lead to snoring, and this can lead to frequent arousals during the evening or during the night hours, so that someone really doesn't get very good and regular sleep. Other problems can be related to, again, the skeletal and oral abnormalities that we see with Marfan syndrome. Sleep apnea or disorders of the sleep are very important, not only for the effects that they have on our breathing, but also for the effects that they have secondarily to how we perform our daily activities, what our ability to focus, our ability to perform during school, during work, and our mood changes. They can also have effects on the aorta and on the intrathoracic pressure, and there are currently studies being performed looking at other physiologic responses related to sleep disordered breathing. Additional systems that can be involved are the skin. Striae or stretch marks are a frequent finding. The stretch marks in Marfan syndrome occur in different locations than they do in people that are not affected with Marfan syndrome. Typically, the stretch marks that we see in those that are not affected with Marfan syndrome stretch marks occur related to increased weight gain and rapid weight loss, and they occur related to pregnancy. In Marfan syndrome, however, they really don't have anything to do with any kind of weight gain or weight loss. They can be related in part to rapid growth of the body, but they also occur in different areas, like here around the shoulder area or the pectoris muscle area, and also along the back. So they occur not related necessarily to weight gain or weight loss and in different areas. Another finding is dural ectasia. This is a swelling of the spinal, of the area of the spinal cord that carries the spinal fluid along the spine. You can see here a little bit of an outpouching, and in more severe cases, these swellings of the sac that carries the spinal fluid along the vertebral column. These can lead to not only back pain, but significant headaches, and are typically diagnosed by an MRI. So making the diagnosis, well, one would hope and one would recommend that the diagnosis is made early and as accurately as possible. In order to do this, it's really important to see a physician or a healthcare provider that has experience in connective tissue disorders. You might recall that the prevalence of Marfan syndrome is 1 in 5,000 individuals in the population, and therefore some places, such as community hospitals, may have never seen someone that has Marfan syndrome. So again, it's important to seek care and evaluation at a center that sees many individuals affected with connective tissue abnormalities. The exam typically should include a detailed medical and family history because it's important to know whether or not there are parents that are affected, as this is an inherited condition, or other family members. A complete physical examination. So for example, I'm a cardiologist. I shouldn't just listen to the heart. I should evaluate or have a provider with me that also evaluates the entire person from head to toe. An echocardiogram is part of the exam because we definitely want to look for any cardiac involvement, for any aortic enlargement, abnormalities of valves, or function problems. An electrocardiogram to look at any rhythm disturbances of the heart. An eye exam is important because, as I showed you in the slides, you need to really look at the lens and also at the back wall of the eyeball or the orbit. And therefore, the eye exam should also include a slit lamp exam with dilation of the eye. CT or CT scan or an MRI that uses magnets may be necessary to evaluate the spine for dural ectasia. A CT or MRI may also be necessary to look at the aorta in further detail, especially when it comes to making any decisions about any type of surgical intervention. And also, when an individual gets to be of adult size, it's often difficult to visualize the aorta all the way throughout its course by echocardiography only. So sometimes, and not sometimes, actually, when people get to adult size, an MRI may be a better way to visualize the aorta than an echocardiogram alone. Genetic testing may also be helpful in confirming or ruling out a diagnosis of Marfan syndrome in the affected individual as well as family members that may be at risk. The revised GAN criteria are the method by which we make a clinical diagnosis of Marfan syndrome. And really what has become of these criteria is that aortic dilation or enlargement of the aorta is a key feature to making the diagnosis. In the absence of any affected family members, aortic dilation in the presence of ectopia lentis, which is a dislocated lens, in the presence of a fibrillin 1 mutation, or in the presence of multiple systemic findings, so greater than 7 according to this criteria list, can make a clinical diagnosis of Marfan syndrome. So again, aortic dilation in all these is key. Aortic dilation or enlargement with any one of these findings makes the clinical diagnosis. In the presence of a family history, ectopia lentis alone, systemic findings more than 7, or aortic enlargement is also important. So in the absence of a family history, you need to have aortic dilation. In the presence of a family history, any of these findings is acceptable. And again, the revised GAN criteria were published by Dr. Bart Loys in 2010 and actually make the diagnosis, I believe, from a clinical standpoint, a bit easier to make than was previously the case. Cardiovascular surveillance, as I mentioned, because of these concerns of progressive enlargement of the aorta and possible risk for dissection, regular surveillance and imaging of the aorta is very important in this case. Typically, when someone is concerned that they may have Marfan syndrome, an echocardiogram is performed initially, and then a follow-up echocardiogram is recommended within 6 months to see whether there's been any significant change in the size of the aortic root. If the size of the aorta is stable, then an echocardiogram is typically recommended annually. Echoes may be asked for more frequently if the aortic root is greater than 4.5 centimeters or enlarging at a fast rate, which is typically greater than 0.5 centimeter per year, or in cases when the aortic valve, which we see right here, and I'll see if I can get this to play, yes, or when the aortic valve, which we see right here, is leaking significantly. One thing I want to bring out here on this echocardiogram is that you can see how dilated and bulbous this aortic root here. This is the mitral valve that we talked about previously, and you can see kind of how floppy it is as it's opening and closing during the cardiac cycle. As I mentioned previously, an echocardiogram may not be the optimal way to visualize the aorta in young adulthood, and therefore an intermittent CT or preferentially an MRI may be recommended in young adulthood and later in life. And those individuals that have had aortic surgery for some reason or other, or for those that have undergone a previous dissection, at least annually a CT or an MRI is recommended. The general management for individuals with Marfan syndrome includes exercise restriction. Typically, exercise restriction includes avoiding any high impact exercises, any high weight weightlifting, any weight training classes. And so I don't want to get into too much detail about this because exercises will be reviewed in later talks. But exercise in general is good in moderation, but there are certain types of exercises that we ask to be restricted. Medical management is typically aimed at slowing aortic growth. Medications typically include antihypertensives or medications that lower the blood pressure and in some cases the heart rate. The typical classes of medications that are used for medical management in Marfan syndrome are beta blockers. These include propranolol, atenolol, and metoprolol, to name a few. Beta blockers typically will lower the blood pressure, but they also lower the heart rate and therefore decrease the amount of stress on the already weakened walls of the aorta. Angiotensin II receptor blockers, typically losartan and irbesartan, to name a few, are medications that block TGF-beta receptors at the cell level. They also work on the blood pressure by decreasing blood pressure, but not only do they decrease the blood pressure from a systemic effect, they also work at the cellular level by blocking the TGF-beta receptors that are related to the connective tissue abnormality. ACE inhibitors may be indicated in those individuals that for some reason or another cannot take beta blockers or an angiotensin receptor blocker. ACE inhibitors have also been shown to slow aortic growth, and these include medications such as enalapril or lisinopril. Surgical intervention to replace the aorta may be indicated in certain cases. Again, there are indications for surgical aortic root replacement. These include an aortic size of greater than 5 centimeters, rapid growth rate of the aorta, or progressive aortic insufficiency. In certain cases, repair may be recommended at a smaller size. That may be related to the rate of the growth and also what the family history is. So for example, if a family member dissected at a smaller size, an elective repair may be recommended sooner. And other supportive services by orthopedics, by pulmonary, by physical therapists may be helpful to support all the other findings that we see that are related to the musculoskeletal systems, ophthalmology for the eye. There are a slew of other supportive services. So again, it's really important to be at a care center that not only provides the cardiac care, but also provides all these other supportive services and referral subspecialists that can help increase and improve quality of life. So in summary, Marfan syndrome is a genetic disorder of the connective tissue which primarily affects the ocular or eye, musculoskeletal, and cardiovascular systems. Cardiovascular complications in Marfan syndrome, as well as in some of the related disorders, can be life-threatening, and therefore early and accurate diagnosis is essential. Regular surveillance, medical therapy, and surgical intervention, if needed, can improve long-term outcomes and save lives. And I can't stress the importance of that regular surveillance and of being at a center that has experience with connective tissue disorders. I do want to bring up sharing of health information. I always recommend that individuals carry medical alert bracelets. These are bracelets that come in all different sizes, shapes, styles, that don't really need to look ugly. They can be actually quite fashionable. But these medical alert bracelets are important because they contain information about an individual's diagnosis and risk, in this case, for aortic aneurysm. So if you're caught in an emergency, for example, a car accident, or in some situation where you can't speak for yourself or advocate for yourself, or there's nobody that knows you and can advocate for you, the first responders at that emergent situation, they need to know what they need to look for first and what they need to prioritize. And in this case, for example, if it was a high impact accident, I would want them to know that my risk is with my aorta first and foremost, and you want to make sure that they triage you and get you promptly the health care that you need into an emergency room with people that know what they need to look for, because time is of the essence in this particular case. Another important feature that the Marfan Foundation has been very involved in is this new Backpack Health app. And at this point, again, this is great for sharing health information amongst different providers. So if you move from state to state, or you get your care from different providers, not only within an institution, but also at different institutions within a city or state, this is a great modality to be able to share your healthcare information with the individuals that you allow to share that with. So I'm going to go ahead and share this back, share the screen back to Eileen, so that she can now go over a little bit more detail the Backpack Health application.
Okay, so let me get back to my screen here. Great, thank you so much. That was really great. As Dr. Young said, I do want to just tell you a little bit more about Backpack Health. She did give you a really good overview to start with. As you heard from her presentation, I mean, there are a lot of doctors to keep track of, a lot of information, a lot of tests that you're having, and reports that you're getting, and usually in a family, it's not just for one person, but maybe for several people in your family. So through this app, it's safe, it's secure, it's easy to use. And also it's in a lot of languages. And so it gives you opportunities to share the information that you want shared with, for example, a new doctor, a school nurse, or even when you're traveling. And it's in a lot of languages. So let's say you go to Paris and you need access to your medical information, even though you uploaded it in English, it translates to French for that use. The other really cool thing about this, which I don't think we can really overstate, we can't overstate the importance of this, is how Backpack Health helps advance research. When you wonder things about Marfan, like, what's the correlation between Marfan and ADD, or, what about sleep apnea and Marfan, which Dr. Young spoke about a little bit. Researchers can't actually study questions like this unless they have information on enough people with Marfan and their experiences. So when you join Backpack and you consent to being in the registry, first, your information is de-identified, so no one can ever associate it with you. And then your information is aggregated with other people who join the registry, and researchers who are studying important questions can get that aggregated data and then look at it and examine those important questions that can impact your life, your kids' lives, and your future generations. So we hope that you will join Backpack, and here's how you do it. In fact, because of our agreement with Backpack, you are going to get the upgraded Pro version for free. Usually there's a cost to that, but if you join through the Marfan Foundation, consent to be in the registry, you get that upgraded app for free. Just go to our homepage, marfan.org. There's actually an icon on the top, this little backpack icon. You'll see that right next to our social media icons on our webpage. So you can just click on that and it'll take you to more information on Backpack Health. It's a great tool, and we really hope that you all will take advantage of all that it offers. So at this point, I want to stop. We have more than 20 minutes left. So we're gonna go through some of the questions that we have here in the Q&A box. And so some of these questions we'll ask Dr. Young, and if she can, hopefully she'll be able to answer things that are even beyond the basics in cardiology. So Dr. Young, do you know of any, let's start with this one from Jessica. Do you know if Marfan is linked to any neurological conditions such as seizures?
So Marfan syndrome and seizures There have been a few isolated reports of epilepsy or seizures with Marfan syndrome, but again, they're very rare isolated case reports. Marfan syndrome and association with seizures is quite rare. I can't give you more information than that. I can say that personally, I have not seen anybody with a history of seizures related to Marfan. But again, there are a few case reports. I would probably defer to a neurologist to see if they have any additional experience, but it's not typically a commonly associated finding.
Okay, great. Thank you for that. Now we're going to get back to something totally in your wheelhouse. You talked about an adult with Marfan needing an MRI. How often should an adult with Marfan have that MRI?
So I think some of that depends on whether or not they have aortic involvement, which most people do, how well we're able to see things by the echocardiogram, and when we're able to see it by the echocardiogram, does that measurement that we're making by echo correlate with what the MRI finding is? So an echocardiogram images the aorta only by two-dimensional imaging. That means it's only one plane that we're able to see and make the measurement. An MRI, on the other hand, is a three-dimensional imaging modality. So, for example, we'll see all the different areas like up the barrel of the aorta rather than just the lengthwise area of lengthwise image of the aorta. So sometimes the MRI measurements may be a little bit bigger than what we're getting by the echocardiogram. So I think if the measurements are correlating, I typically leave it up to the physician. If they're correlating once every couple of years, if there's no significant changes that are occurring, if they don't correlate, then I would go with the I would go with the MRI rather than the echocardiogram, and I would say probably every year or 2 years.
Great, thank you. And now we have a question from Grace. Hi, Grace. She wants to know if you can tell if a baby has Marfan syndrome before they are born.
So I briefly talked about findings being present at birth. Infantile Marfans or neonatal Marfans is probably the most severe form of Marfan syndrome. And babies with Marfan syndrome typically have pretty severe, significant findings, more so than those individuals that present later in life. Many times, heart failure is a big problem and can also be a cause of death early on during the first year of life with infantile Marfans. Some of the findings that prenatally might be seen, let's say on a fetal echocardiogram or an ultrasound of the heart, might include aortic enlargement, floppiness of the valves, like we reviewed here, also, on the echocardiogram after birth. The floppiness of the valves, leakiness of the valves, cardiac enlargement, and cardiac failure can also be seen prenatally. Again, those findings aren't always present. So that's, for example, in an infantile Marfan presentation, not always are the findings present at birth. So if someone knows that they have Marfan syndrome, let's say a mother has Marfans or the father has Marfans, a fetal echocardiogram is recommended. Genetic test, prenatal testing can be performed, but really you're still going to need the follow-up after birth to see if any of those findings develop. So just because you have a normal fetal echocardiogram prenatally doesn't mean that you might not have Marfan syndrome. Does that make sense?
What about like just a regular sonogram? I mean, you could see the bones and everything. Would you, if you're looking because it's a 50-50 chance with the baby, do the bones show any indication? Obviously, you have to wait. You still have to wait, but would that give you a hint?
I think you may see it, but again, I would defer to an MFM specialist. Typically, when I get the referrals, it's more for looking at the cardiac problems, and those are more severe prenatally.
Sure, that's totally fair. All right, well, I'm going to give you this is right in your cardiology area, but I know this is a big question. So, which medicine, atenolol or losartan, is better, and what about recent research?
So the Marfan trial was a large prospective trial that was performed recently that included over 600 individuals from the ages of 6 months to 18 years with Marfan syndrome. And what the trial was specifically looking at was whether or not losartan was any better than atenolol. And really, much of the question came up because genetically engineered mice models of Marfan syndrome actually showed a really great response to losartan. And in some cases, the losartan not only slowed the growth of the aorta, but returned the size of the aorta to normal in certain of the mouse models. Because of that excitement around that great response that the mice were having, we needed to have a powerful clinical trial to prove whether or not the same response occurred in humans. So over 3 years, individuals were enrolled that had aortic enlargement, and they were blindly put into a group with atenolol and a group that was treated with losartan. At the end of that 3 years, it was found that the atenolol and the losartan had similar findings, similar effects. The losartan, that similar slowing of aortic root growth, and so there really wasn't a marked difference between the two medications. The two medications, as I mentioned in my talk, actually work by two different modalities. The atenolol works by slowing the heart rate and average heart rates throughout the day, so less peak heart rates or less high peaks throughout the day. It also lowers the blood pressure, whereas losartan not only lowers the blood pressure, but also doesn't affect the heart rate, but affects the target tissue and the TGF-beta receptors within the tissue. After the trial, did not see any significant difference between the two medications. Both had a low incidence of adverse side effects, and those adverse side effects were not severe. So similar results. And one important thing that the trial did come up with was that it showed a greater benefit when medications were started earlier in life rather than later in life. So better benefit when the medication was started earlier, and again, no significant difference between the two medications.
Great, thank you. That was very thorough. Here's a question about having surgery. So if you had an aortic repair done at a younger age, what's the likelihood of a second aortic repair later in life?
So that's a really important question, and thank you for asking it. When the aorta is repaired, the area that it is repaired typically will not change over time, but areas of the aorta, remember this is a systemic disorder, and so it can affect other areas further down the tube, if you want to simplify the terms, but it can affect the aorta further down the road. And so for that reason, it's really important that even when you've had surgery done early in life, that you still have regular surveillance with a cardiologist and regular imaging of the aorta, because there are occasional instances where a second surgery is needed because of enlargement of the aorta further down the line past the area that was initially repaired. I don't have a percentage that I can give you. Every individual, I believe, is different, but it is known that the distal aorta can become a problem, and that's the reason why even after you've had a surgery, it's still important to maintain regular follow-up with a cardiologist and regular imaging.
Great. Thank you. That's really important. That was a great question. I'll take this question about Backpack Health. And so the person's asking, will Backpack Health compile all prior medical records from doctors in different states? Actually, when you subscribe to Backpack Health, you upload your own medical records. So you have your medical records, which you're keeping track of anyway, hopefully, maybe in paper or whatever, and you upload them. And we do encourage people from every state and from all over the world to participate in this. In fact, we have people from 49 states already in Backpack, and so if anybody on this call is from Hawaii, please subscribe so we can say that we're covered by all 50 states. But yeah, we encourage everybody to subscribe. Get your records on there for your own good, and then also for research purposes. So hopefully that helps. Okay, so Patricia is asking how young a child can be diagnosed. Her granddaughter's 7 months old. So
some of that I think is dependent on whether or not you know that the mother or father have Marfan syndrome. If they have it, you can do target testing for the same genetic mutation. But as I mentioned earlier, many of the findings become more prominent and more identifiable, might you say, as people age, okay? So more obvious, more prominent features as a person ages. So depending on whether the aorta is enlarged, depending on whether or not there's a family history, whether there are any eye findings, I'm not sure that the age so much matters. It depends what the family history is, what the echocardiogram shows, and what the rest of the physical exam shows. So I think if you're concerned about it, I would make sure that they be seen by a specialist that's experienced in it.
It's a great answer.
Does that sound fair?
Yeah, that was really appropriate, because I think sometimes you get tied up with the diagnosis and it's saying, do I have this or do I have that, or does my child have this or that? And I think, people really have to think about what features do they have and treat those. And, if they add up the diagnosis, then they have that like definite diagnosis. But if it doesn't add up yet, they still, if they have their aorta is enlarged, it has to be treated, or they have to be followed, so.
Right. And sometimes not all the systemic features are present that clinch the diagnosis. And so it's not infrequent to have someone come back in a year or 2 years for a follow-up echocardiogram, for a follow-up physical examination, because again, as an individual ages, those findings become more clear and evident over time. And so let's say you don't have all the features, at 7 months, perhaps at a year, 2 years, 5 years, they may become more evident.
It's interesting when those new criteria came out in 2010. I mean, one of the possible diagnoses for when you're getting evaluated for Marfan is something they called emerging Marfan, just for that reason, because it's not like you don't have it now, so have a nice life, see you whenever. It's you don't have it now, but let's keep checking just to make sure.
Right,
so.
and along that, and to follow up on that, a normal echo doesn't necessarily mean that you don't have it. So a normal echo today doesn't necessarily mean that you may not develop findings over time and have an abnormal echo later on.
Right. Great. Okay, here's a quick one. So what type of doctor is recommended for sleep apnea diagnosis and treatment?
So typically a pulmonologist. And so a referral to a pulmonologist with a specific request to rule out the possibility of sleep apnea. And typically what they'll do is order what's called a sleep study, where you come into the hospital and they monitor your breathing, your wake cycle, your sleep cycle, blood pressure, vital signs, etc., while you or your child is sleeping over 24, overnight. So it's a pretty complex exam. But it's ordered by a pulmonologist, and the specific study is a polysomnogram, or a sleep study in lay terms.
Great. Here's a really good question, especially with the advent of all this genetic testing. How important do you think genetic testing is if a diagnosis has already been made clinically?
Well, I think genetic testing is tricky. So I think genetic testing is really good if you're concerned that you might have the diagnosis, but you're not completely 100%. I think genetic testing can potentially confirm it. However, we need to remember that the human chromosome is infinite, and we don't have all the genetic testing. All the genes have not yet been discovered that potentially cause Marfan syndrome. And so every year there are new genes that are being discovered. And I think it's really important that just because you've seen, for example, a geneticist one time in your life, to follow up with that geneticist, because I've had a few cases, at least in my practice over the last 10 years or so, that were initially thought to be Marfan syndrome, but didn't quite meet all the criteria for a nice, black and white case of Marfan syndrome. And then new genes came out, and it turned out that they had Loeys-Dietz syndrome, or they had some other type of syndrome. So I think it's really important to continue to follow up with a geneticist, because there are new tests that come out every year. Again, I think that if you have a clinical diagnosis, the genetic testing is helpful to confirm it. But just because it comes back negative, if you have all the criteria, I don't think you can ignore, just because you have a negative test doesn't necessarily mean you don't have it, if you're meeting all the other criteria.
So complicated.
Yeah.
So complicated. What is the quality of life for somebody after aortic surgery?
Well, I think, with the advent of aortic surgery, many moons ago, individuals that had Marfan syndrome with aortic involvement didn't live until, the age of 40 or 45. That was the usual life expectancy because of dissections, because of problems with aortic insufficiency, etc. However, with aortic surgery, people's life expectancy are now normal. I mean, as long as you follow regular follow-up, you see your cardiologist, you have your surgery when you need to, you follow the appropriate recommendations. The life expectancy is really pretty much to normal at this point. So I feel that quality of life with surgery, with an aortic aneurysm, you may not even know you have an aneurysm unless you have aortic insufficiency or leakiness of the valve. So it's one of those silent kind of things that unless you look with an echocardiogram, you may not even be symptomatic from the aneurysm itself until it actually tears and becomes a medical emergency. So the imaging part of this is really important. Symptomatology is usually related to aortic valve leakiness, rhythm abnormalities, mitral valve leakiness, or left ventricular or pump function problems, and not everybody has those. So when you say quality of life, if your quality of life is related to dysfunction of your valves or left ventricular dysfunction, surgery may help improve that. And I think that when we think about surgery for aortic root replacement, it's more of trying to prevent an emergent tear of the aorta, and that's what the usual indication will be. That's a roundabout way to answer that. I'm sorry.
No, that's good. I'm going to just answer a couple of these quick questions here as we're nearing the end. Somebody asked about the PowerPoint. I'm going to check with Dr. Young and make sure we can get make a PDF of it available so you guys can refer to this. There are several questions, and I saw some conversation during the hour about doctors. We do have an institutional directory on our website, but also Jan Lynch in our help center, who may be listening in as well. She also has more resources, and I'll be posting her information later. I also saw a question about endovascular stenting, and there is a statement on that on our website. Let's see, anything else quick the GAN criteria is on, it should be on, actually, if you go to our website, marfan.org, and look at Marfan DX, that's a tool for doctors, but you guys can take a look at that. So go to our website, marfan.org, and search for Marfan DX, and you will see that. I think a lot of these, there's some really, really great questions, you guys. This was really good. You're also good about asking general questions. We could do another hour, but we're not going to. I'm going to take these questions, and between Jan answering them with you directly, I may be able to put some of these in connective issues or in e-news or on our social media, but these are really great questions, and we do want to get back to you with those. And so unfortunately the time is running out, and I have a couple more little odds and ends I just want to share with you. But that was really great, and thank you, Dr. Young, for all of that.
Thank you.
As I mentioned, Jan Lynch is a nurse who is the head of our Help and Resource Center, and there she is. I think she's driving somewhere right now, so she's listening. If you go to our website and go to ask a question, that's another way that you can ask, get your questions answered by Jan. She's busy all day, every day, answering your questions. Our next webinar is going to be on Monday, October 15th. And it's going to be on taking care of your aorta. So some of these questions you guys asked a little more in depth about stenting and all sorts of other things that are coming up in taking care of your aorta will be addressed more in depth by Dr. Braverman on Monday, October 15th. You can go to our website to register for it. If you see, you'll also be able to find the recordings of this webinar and other webinars. Go to marfan.org, patients and families, and then you'll see virtual medical symposium series over here. Underneath this is the empowerment series, which are webinars that we started in January on quality of life issues. So you can take a look at that. After Dr. Braverman does his talk on the aorta, in November, we're going to have Dr. Hal Dietz talking about Loeys-Dietz syndrome. So that is going to be really informative as well. So, thank you all. There's so many more questions here in the chat box and in the Q&A, and we're not going to be able to get to them right now. But thank you so much for your time tonight. Thank you, Dr. Young. This was so informative. question and answers particularly really, really helpful. If anybody has any further questions or any suggestions for future webinars, feel free to email me. The easiest email to remember is publicity@marfan.org. And thank you again for your time tonight, and have a good night. Hopefully we'll see you at the next webinar.
Thank you. Good night, everybody.
Night.